Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Hello, I'm Colin Crowe, an assistant professor of family medicine at Case Western Reserve University, family physician, and a member of Cardio's Team Best Practices. Today, we're exploring an essential communication technique in healthcare that can have a big impact on health outcomes. I know that's a pretty bold statement, but what if I were to tell you that there's a way to help people of all backgrounds and education levels to decrease 30-day hospitalizations by 45%, increase condition-specific knowledge, and improve patient satisfaction and self-care behaviors? Even better, this method can take as little as a couple of minutes and be used by all office staff. Research demonstrates that it's possible to achieve those remarkable improvements with the help of a patient communication technique called the teach-back method, or closing the loop. To tell us more about patient communication and learning, I would like to introduce our guest for today. Dr. Esther Thatcher is a nurse scientist in population health at University Hospitals, an adjunct assistant professor at Case Western Reserve University's Francis Payne Bolton School of Nursing, and Dr. Sonal Patil is a family physician and health services researcher from Case Western Reserve University, whose research focuses on interprofessional team member interventions, targeting cardiovascular health disparities. Welcome, Drs. Thatcher and Patil.
Thank you so much for having us.
It's great to be here with you to talk about the teach-back method.
Thank you for being here. So let's get right into it. I'm going to start with you, Dr. Patil. I've heard that you became interested in teach-back because of a particular patient case in which you were feeling pretty frustrated. Can you tell us about it?
Sure. I had a patient whose blood pressure remained high despite being on the maximum dose of a diuretic. So I recommended adding another medication, losartan, starting at the lower dose, and asked her to come back in a month for a follow-up blood pressure check with the nurse. When she returned for the nurse visit, her blood pressure readings remained unchanged. The nurse confirmed that the patient had been taking her medications regularly. I scheduled a follow-up appointment and asked the patient to bring all her pill bottles. At that visit, while reviewing her medications, I realized she didn't have the bottle for the diuretic. It turned out she had stopped taking the diuretic because she thought the new medication replaced the first one. When the nurse asked if she was taking her medications regularly at the nurse visit, the patient said yes, because she was taking losartan regularly as prescribed. Many providers overestimate their ability to communicate information. But without confirming the patient's understanding, it can lead to what we perceive as non-adherence. In reality, it is often a failure in communication on the clinical team's part.
That term you just used, non-adherence, our listeners might recall it was formerly called non-compliance, which, for better or for worse, was the medical term used when patients don't consistently follow through with recommendations for medication taking, diet, exercise, and other things.
Right. It's one of the greatest challenges in healthcare, and there were many factors potentially affecting my patient's ability to take her medication as prescribed.
Before you tell us what happened, let's talk about what types of things affect a patient's ability to follow through with our recommendations, whether it's for medication taking or more broadly.
Medication adherence is the extent to which a person's medication taking behavior corresponds with the recommendations from their provider, which is key to making it possible for patients to get the most benefit from their medications. There are many factors that can contribute to a person not taking medications as prescribed. These might include social and economic factors, healthcare system challenges, condition-related concerns, patient-related concerns, and of course, treatment-related concerns. Ultimately, it is important to understand why a patient may not be adherent in order to identify a patient-specific solution.
That makes sense. Good patient education is essential for helping patients take their medications properly.
But it's not only communicating the best we can. It is also essential that we make sure that the patient understands us. I discovered I was falling short by not determining if my patient had a good working knowledge of how to take the medication. Teach back is simple but powerful technique that can make all the difference in health outcomes.
Okay, so let's talk about the technique itself. How do we do it? From your patient case, I gather it's not just asking the patient, do you understand?
Yes, let me explain further. With teach back, you carefully and humbly, sincerely ask the patient to tell you what they understand. You conduct the visit as usual and explain the diagnosis and treatment. But what is different is that instead of asking, do you have any questions, or simply asking, do you understand? You or your staff members ask the patient or family member to explain in their own words or to demonstrate what you just told or showed them about the health condition or treatment. I would be happy to go over the specific teach back steps in a bit.
That would be great. In the spirit of TeachBack, let me check my understanding. So, TeachBack is a tool that you and staff use to help determine the extent to which patients and families understand the information you've shared with them or the skills you've taught them, regardless of their level of health literacy. If necessary, you could clarify any misunderstandings or missing information.
That's right. It assures that the patient and their caregivers understand what we have said. It has been shown to take only 1 to 2 minutes of provider's time. It should be done near the end of a brief encounter, or in more complicated visits, it helps to ask immediately after critical information has been given. A quick way to do this is simply say, I want to be sure I have explained things clearly. In your own words, please tell me your understanding of. A benefit of this in a busy primary care setting is that it does not require any additional equipment, only takes a few minutes of time, and can be used by any member of the clinical team.
We'll go through an example in a few minutes, but first let's pivot to Dr. Thatcher. Can you explain how TeachBack fits into health literacy, which is a term that has been mentioned several times during our discussion today?
Thanks for bringing this connection up. Health literacy for each of us is the ability to find, understand, and use health information in order to make informed health decisions and actions, no matter who we are or what our level of education is. Health literacy is one of 5 Healthy People 2030 overarching goals to eliminate health disparities, achieve health equity, and attain health literacy, and to improve the health and well-being of all. In a landmark work from 1999, the American Medical Association found that health literacy is a stronger predictor of health status than age, income, employment status, education level, race, or ethnic group.
Wow, that's worth repeating. Health literacy is a stronger predictor of health status than age, income, employment status, education level, race, or ethnic group. That's astounding. So health literacy predicts health status at a very fundamental level. But health literacy varies from one patient to the next. How can we tackle such a complex problem?
We take a cue from infection control and practice universal precautions. As healthcare providers, we practice universal precautions for disease spread because we do not know what we can be exposed to or what we can expose patients to. In a similar manner, we cannot know the health literacy of a given patient on a specific health-related topic, and thus we should practice universal precautions for health literacy. This universal approach means treating all patients and families as if they are at risk of not understanding health information. TeachBack is an important tool in the Health Literacy Universal Precautions Toolkit that bridges gaps in understanding. The Agency for Healthcare Research and Quality has developed a Health Literacy Universal Precautions Toolkit for providers and staff that is freely available. We will post a link to it in the show notes.
Can you tell us how TeachBack fits into existing approaches to patient-centered communication?
TeachBack meshes well with motivational interviewing, which is a collaborative communication approach that strengthens a patient's motivation to act. Cardi-OH has great resources on motivational interviewing, which we will also link in the show notes. Motivational interviewing provides a 3-step process for sharing information with patients called Ask, Tell, Ask, similar to TeachBack, in which the provider shares information and then asks the patient to share their understanding of the information.
Can you explain how the first step of that could be used to lead into TeachBack?
I'd be happy to. The first ask in Ask, Tell, Ask is an open question to explore the patient's prior knowledge of the subject at hand, determine their level of interest, or find out what they want to know. A good general communication principle is to not tell people what they already know. For example, a clinician might say, "I don't want to repeat information that you already know. So can you tell me what you know about this type of blood pressure medication? If you're not familiar with it, that's okay."
That could save the clinician some time.
Right. If the patient demonstrates that they already know important information about the medication because they have taken it in the past or they helped a family member who has, you won't have to explain what they already know, and it may also help maintain the patient's attention during the visit. It's also respectful to acknowledge that the patient may already have knowledge about the subject.
You mentioned that this lead-in to teach back, ask, tell, ask, can be used in other ways.
Yes, if you ask the patient to share their questions or concerns before you share information, you can more effectively address the patient's interests or concerns. For example, what would you like to know about this new medication? What do you think would be the biggest benefit of high blood pressure medication for you? Or what concerns do you have about taking this medication? The information shared by the patient enables the clinician to better address their needs.
Yeah, I can see how that would be useful to have that kind of information before starting to share what we think the patient wants and needs to know. The clinician could be more efficient and accomplish more with the patient during their visit.
That's right. We can better tailor the information sharing step. You can also use this lead-in to simply ask permission to share information with the patient. For example, is it okay if I explain how to take this medication? Asking permission is used in motivational interviewing to emphasize the patient's autonomy and communicate that the patient also has a voice in determining what takes place during the visit.
So we ask the open question, the patient replies, and then what's next?
The clinician can acknowledge what the patient said by reflecting it in a paraphrase and indicate their willingness to address their questions or concerns.
Do we move into teach back now?
Yes, and it's pretty straightforward. Step 1 is to present the information to the patient clearly and simply, starting with the most important points, some of which may address questions or concerns the patient brought up in response to the lead-in question.
Okay, so it might be something like this. The pills I'm going to prescribe are intended to keep your blood pressure in a safe range. Take 2 tablets in the morning with breakfast for the first 14 days. After that, take only 1 tablet every morning with breakfast.
You've got it.
So what's step 2?
Step 2 is to invite the patient to explain it back to you in their own words. The clinician should let the patient know that the onus for communicating effectively is on the clinician. So you could say, "To be sure I explained this clearly, can you tell me in your own words how you will take the medication?"
So if the patient doesn't quite get it right, they don't feel like they've failed a quiz.
Exactly. We want the patient to understand that we are asking to be sure that we explain the information effectively enough so that they understand it. If the patient doesn't understand, it's on us to re-explain it in a way that the patient can understand. But we won't know if they understand unless we ask them to explain it back to us.
Okay, what's next?
After listening to the patient explain the information in their own words, we can either acknowledge that their understanding is accurate, or we can re-explain it if there are inaccuracies.
Can you say some more about that?
If the patient doesn't explain it back to you correctly, take responsibility for the misunderstanding, re-explain it, and then ask them to explain it back to you again in their own words as before. If there continues to be a discrepancy, repeat this step until the patient can demonstrate that they clearly understand it. Depending on the content, it may not be limited to verbal explanations only. Demonstrating how to use devices is also important. Using different modalities can improve understanding. Things like writing the times of day for medications and their dosages on a calendar, or writing down steps for using a device. These are things the patient can take home with them.
Is that everything?
One final step is to summarize the key points and confirm understanding.
Okay, let's see if I've got the steps of teach back right. Step 1 is to explain the information to the patient. Step 2 is to invite the patient to explain it back in their own words. Step 3 is to either acknowledge that the patient understands the information or address any misunderstandings or gaps in the patient's knowledge by re-explaining. If you re-explain the information to the patient in step 3, then step 4 is to ask the patient to explain it again in their own words. Steps 3 and 4 can be repeated until the patient can explain the information back accurately. And then step 5 is to summarize and confirm the patient's understanding.
That's right.
Thank you, Dr. Thatcher, for the overview of the teach back method. So, Let's now complete an example for a patient with hypertension. I will play the role of the patient in this one. Dr. Patil, you can be the provider, and Dr. Thatcher, can you do the play-by-play of how the technique is being used?
Okay, we'll start with a lead-in question from Ask, Tell, Ask. This patient often had concerns about new medications interacting with her current medications, so Dr. Patil will ask about any concerns she may have.
To begin, Ms. Brown, what concerns do you have about the new blood pressure medication we have been discussing?
Well, I'm already on so many, and this will be another one. Won't this interfere with some of my other medicines, like my diabetes medicine?
So that was the lead-in step from Ask, Tell, Ask. Now we will start the information sharing step in TeachBack, which will start with a response to the patient's question.
That's an important concern. I have checked the top database for potential interactions with your other medications, and there are no known or expected interactions. This blood pressure medication has a long track record of being taken with the same medications you're taking without problems. I don't expect any issues, but please contact the office if ever you think you may be having a problem.
That's reassuring. I'll let you know if I have any problems.
Good. Now, I would like to explain how to take the medication. Take 2 amlodipine tablets in the morning with breakfast for the next 14 days until you use up the tablets that you have at home. After that, you will take only 1 tablet every morning with breakfast rather than 2. So that I can be sure I did a good job of explaining how to take the medication. Can you tell me in your own words how you plan to take it?
Sure. Let me see. I'll take 2 pills in the morning for 2 weeks. After that, I'll take 1 pill in the morning when I need it, rather than 2.
The first part is perfect. As you said, you will take 2 pills in the morning for 14 days. But I should have been clearer that starting on day 15, you will take 1 pill every morning, not only on days that you feel you need it. So again, you will take 2 pills in the morning for the first 14 days and 1 pill every morning from day 15 onward. So that I can see if I explained it better this time, can you tell me in your own words what you plan to do?
I think I understand now. I thought that after the first 2 weeks, I should take the pills only when I needed them, like if I'm feeling lightheaded. I guess that's because my dad took his blood pressure pills that way. Okay, I'll try it again. I'll take 2 pills every morning for 14 days and then 1 pill every morning from day 15 on. Is that right?
Right. So it's 2 pills in the morning for 14 days and 1 pill every morning from day 15 onward.
I've got it.
So you can see in this example that adherence was the main reason the patient's blood pressure was uncontrolled, and addressing this with education and the TeachBack method should help improve her disease management.
That was pretty simple. It really just took a few minutes. Why are we not seeing this in all practices and in all settings?
TeachBack is effective in improving self-management, quality of life, and readmissions in patients with chronic conditions. But its routine use is limited. We assume all our patients can process and understand all the health information, but almost half of our patients misunderstand directions for taking their medications. For example, one of our family friends with a doctorate in the financial field told me about her recent diagnosis and treatment of hypothyroidism, and that she was due for a recheck of her thyroid levels in a week. I asked her if she was taking her thyroid medications regularly, and she stated she had finished the bottle of pills from the initial clinic visit few weeks back. I asked if she did not get any refills, and her response to that question was, "What is a refill?"
Wow, that is surprising. It really drives home how any individual can miss critical information. Do you think this kind of misunderstanding is common, even among those who might seem like they would be well informed?
Yes. In fact, the majority of patients, no matter their education level, have limited knowledge of self-care behaviors and medication adherence. I realized refilling is an unknown concept for my friend and possibly for many people outside of the healthcare field without chronic conditions. When I checked my friend's thyroid medication pill bottle, she had 2 more refills. I reviewed the process of requesting refills through the refill line with her prescriber.
Wow, that really shows how knowledge gaps can lead to misunderstandings and why implementing TeachBack in clinical practices is so important.
Absolutely. We need to understand and address the interpersonal and contextual barriers to implementing teach-back methods, especially in primary care. Implementing teachback in primary care practices can be challenging due to the mere number of preventive and chronic care issues addressed in each 15 to 20-minute primary care visit.
Right. It's a significant hurdle. So do you think these time constraints lead clinicians to skip the teachback method altogether? And if so, how can we ensure that that doesn't happen?
Great question. The core of teachback is simplifying complex information into understandable chunks, which is incredibly important in primary care settings. Primary care visits result in complex after-visit actions and instructions. That is, patients must follow up on a significant number of action items and behaviors to achieve improved outcomes. Making sure patients have a clear understanding during the visit can help reduce follow-up phone calls and messages to primary care teams. Due to time constraints, team-based care is particularly important for teachback implementation in primary care. Interdisciplinary care with nurses, pharmacists, care navigators, and health coaches can be crucial for improving teachback and care plan adherence.
Well, that certainly sounds good, but how can communication stay clear and consistent with so many team members?
Quality improvement initiatives can help develop clear and consistent communication across team members. In fact, implementation studies for teachback strategies have primarily focused on training and educating nurses. Physicians need to list all of the required action steps in the after-visit summary or communicate clearly with their nurse teammates. Nurses can go over the after-visit instructions in the clinic using teachback to ensure patients understand all the discharge instructions and the next action steps.
Are other health professions using teachback?
Chronic disease care management with clinical pharmacists can be extremely efficient and effective for teachback on medication use and improving medication adherence. Health coaches, who are patient-centered team members supporting chronic disease self-management and navigation of health systems, have been shown to improve adherence to preventive inhaler use and demonstrate the perfect technique of inhaler use using standardized teachback checklists. The teachback technique for proper inhaler use and home blood pressure monitor use requires approximately 8 to 10 minutes, which can be challenging in time-constrained primary care workflows. Pharmacists, health coaches, or community health workers can effectively use teachback to improve techniques of monitoring and medication device use outside of clinic visits. Lastly, language and cultural barriers for migrant and refugee populations can add a layer of complexity, and language interpreters are necessary team members to support teachback in this population. Language interpreters, community health workers, or peer health coaches are more likely to use plain language and avoid medical jargon when using teachback, and this can promote trust, understanding, and adherence in socially disadvantaged populations.
That's all great information. You mentioned the training and education to improve teachback. Are there any free resources or toolkits to support teachback training and evaluation for clinical teams?
The Agency for Healthcare Research and Quality has freely available materials and toolkits, including an interactive learning module to implement teachback in primary care settings. Quality improvement initiatives can review teachback practices in the clinic and provide training to staff on effective communication strategies.
Dr. Thatcher, as you've said, there's a clear connection between teachback, health literacy, and better patient outcomes. This method is so important for our listeners and for the patients we care for. Can you summarize for our listeners what you've told us about the teachback method? And how can we all get started with teachback?
The teachback method helps overcome low health literacy, improves patient-provider communication, and increases patient satisfaction. All healthcare professionals should learn to use the teachback method. Getting started is easy. To learn more about teachback, there are toolkits and resources freely available online, such as from the Agency for Healthcare Research and Quality and on the Cardi-OH website as well. We will link to an example in the show notes. Next, try out the teachback method with patients. Start slowly. Make a plan about how and when to add this to the patient encounter and plan what you will say. Practice with a few patients to see how that goes and learn from their responses. Keep practicing to get more comfortable with it. Eventually, the goal is to use the teachback method with every patient every time.
I like that. Every patient, every time. Dr. Patil, before we go, can you tell us what happened with your patient? How is her blood pressure now?
The patient is doing great. Thank you so much for asking.
I'm glad to hear that. This has been such an informative and relevant discussion. Thank you again for your time, Dr. Thatcher and Dr. Patil.
It was a pleasure participating in this conversation.
Yes, thank you. I enjoyed the discussion on such an important communication technique.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.